let's get started. So Priya met Sebastian, and Sebastian identifies the children. He goes out into the villages and he prepares a list. He puts the children into groups of 10, and Priya uses the equipment of an ophthalmology colleague who charges £2.50 each child assessed, and Priya was given the services free. So what have we done? We've held 5 eye clinics, stroke camps, in March, April, May, July and September 2017, where 6 to 10 children are seen at each eye clinic. Sebastian informs the parents of the dates and attends with them. Priya assesses the children and records the age, gender, diagnosis and treatment plan of each child. And Hugs, that's our charity, finances the cost of water, drops and spectacles. And on our PowerPoint presentation, we've actually got a sample data of Priya's work. So what have we achieved? Well, out of the 89 children, 43 have been assessed by Priya. 22 have been treated with spectacles or eye drops. 8 referred to the Mengo Hospital, where 3 have had operations for cataracts and 3 more are waiting for operations. 2 children have died, one from a congenital condition, the other child, Florence, from unsuccessful treatment of an orbital tumour. Included in those assessed at the Mengo Hospital, Aaron could not be treated there because his condition was too complex, but he's now had one eye transplanted at Dr. Agarwal's clinic, which costs £2,000 each eye, but there's no treatment yet for the other eye. Therefore, 25 children from this project have been fully treated, 18 children assessed but untreated, 46 children still waiting to be assessed, and the probability is there will be 64 children needing treatment. So what have we discovered? We found the eye conditions fall into 3 distinct groups. 1, those easy to treat with eye drops or spectacles. 2, those requiring surgeries, for example, like cataracts. And 3, those children in need of complex and expensive treatment, for example, corneal transplant and orbital tumour excision. In group 1, there were 17 children who were treated for allergic conjunctivitis, and they were treated with eye drops. 1 was treated with block punctum, which was treated with eye drops, and 1 child had astigmatism and was treated with spectacles. 3 children had simple myopia and were treated with spectacles. We found that the children in group 1 could be easily and inexpensively treated. In group 2, there was nowhere to send these children who needed surgery, as there was no funding available. Again, the internet helped, with connections made via the London School of Hygiene and Tropical Medicine. We connected with Dr. Rose Matumba at the Mengo Hospital, and 3 children have been treated by their poor fund, and 3 children are still awaiting treatment. This was a very positive pathway with the Mengo Hospital, but it was very expensive for Hugs, because we had to pay for transport from Jinja to Kampala and paying overnight stays for food and medicine, and follow-up also necessary. In group 3, conditions diagnosed by Priya included retinal detachment, glaucoma, corneal dystrophy, low vision, retinitis pigmentosa, refractive error and congenital motor nystagmus and orbital tumour. We discovered there was no public service provision available for corneal transplantation, only private and very expensive. In the case of Aaron, he was assessed 4 times. His corneal graft treatment was funded by Primrose, working extra shifts and fundraising events. There was lots of follow-up appointments and unexpected costs for Aaron. In the case of Florence, the 12-year-old girl with orbital tumour, she was assessed at the Mengo Hospital, referred to the Malago Teaching Hospital for radiotherapy. The machine was broken and she died while awaiting treatment. Findings of this small project. Many children have not had access to eye examination. The children that are assessed are left at the assessment stage as parents cannot afford the treatment. No one follows up the child when assessed. Doctors appear overwhelmed by the number of children who need eye treatment, and the eye charities do not appear to reach all who need them. We also found that children are not attending school because of eye problems. Children like Florence died because of lack of medical facilities. There are many children in Jinja who cannot access eye treatment. Children, as I've said, do not attend school because they can't see well enough to go. Children who are assessed are left at the assessment stage. No treatment unless you can pay. Private hospitals can do the operation, so there are facilities in Uganda, but they're very expensive. Parents' hopes are raised, but expectations not met. Parents are financially poor and have to balance the need to pay for treatment against other commitments. Eye charitable organisations can help if they have a current project, but many do not have a project available in that particular area. We also found that there's a lack of eye specialist staff and it's difficult to access funding for the sight restoration project. We also had some positive outcomes. Through our contact with Sight Savers, we helped one adult to have cataract surgery. Hugs have paid for a motorcycle for Sebastian so we can go into the villages to find children who require eye treatment. Hugs are going to fund to optometry students over 3 years, so there will be 6 extra optometrists to work in Uganda. Priya is currently in discussion with the Makerere University to facilitate this. Primrose is going to Uganda with doctors and nurses to carry out eye surgery, and our children from Jinja will be invited to that treatment, and I will bring you up to date with that shortly. Through this project, we have enabled Primrose to connect with Sebastian and Priya and the Mengo Hospital. Through this small project, we have raised awareness and brought to the attention of those in power the plight of these children, and we hope this will have an impact on future care. Now, as I mentioned, Primrose was going with a group of doctors and nurses to Kampala. This was organised before she actually contacted us, but we've been able to help to facilitate some of the connections she's made. Also, she invited our children from the list of 89, and from the work that she did last week, 22 children from our Jinja group were fully assessed. In group 1, those easy to treat, 11 were given drops or spectacles. From group 2, those requiring surgeries, 3 children had surgery. From group 3, those needing complex intervention, 8 children have been referred on to other hospitals. So 53 children have been treated under this sight recovery project. We still have 36 out of the original 89 on the list to be seen. And Sebastian says the Labago camp benefited 22 children. And then we finish, I hope you can see this, I'm not sure whether you can, we finish with a picture of Primrose with Sebastian. Aaron has been seen at the Georgia Clinic, and we were hopeful that his second corneal transplant will be done. However, we've since heard that, unfortunately, we don't feel it will be done there. So we're looking for people who may be listening to this to see if they've got any provision in Uganda that could help Aaron 2 other children who need corneal transplants, and the rest of the 30 children. Have we got this now?
No, what's the same?
The cost of this to date has been £3,000, with the majority being spent on the corneal graft for Aaron. In Group 1, the average cost per child is £50. In Group 2, the average cost is £150. In Group 3, it can be up to £2,000 for one corneal graft.
They're conjoining that as...
Right. I think that really concludes the presentation. Both Sebastian and Priya have joined with us, and if there are any questions, we would be happy to take them.
Bob. Hi, Bob.
Hi, Bob.
Now, we can't hear anything, Henry. Can you hear us?
Bob, I can hear you.
Yeah.
Good.
I think we've finished now, Henry, so we need some questions.
All right. So I will also throw that question back to the participants. We have participants who have been listening to this, but maybe I would add something. First, I want to appreciate the presentation. It was really very informative of what the project is doing back in Jinja. The Project Uganda, in which Prim is coordinating Uganda, has actually done a great job, and at the end of your presentation, you talked about the children who have benefited from the camp. We actually joined hands with the Project Uganda and Lubaga Hospital and the Opramoje Society Uganda to organize the camp, which took place last week. That was on 20th and 21st. And it treated about 700 patients standard for that camp. It was the first of its kind within the hospital. And like she shared with us that 20 children from Jinja, from that site restoration project, have benefited from the camp. It's really been because of the effort of both HUGS and Project Uganda, Lubaga Hospital, and then the Uganda UK Health Alliance, bringing together all these partners together in what we've called a health consortium. And we are looking forward actually to having more partners, and then also to, we've seen that there is a challenge of funds. So we're looking forward towards joining hands with the partners who are within the consortium to find alternative mechanisms of funding to ensure that these children are supported to get the health care, especially their eyes, and perhaps also to get their livelihood like HUGS is taking care of. We much appreciate that. I want to appreciate Sebastian. He was actually at the camp. He was one of the men that came around with the children, and we had a good time around with him. So we appreciate HUGS for having contributed in such a manner, and then for supporting the children to travel from Jinja up to Kampala to get the treatment. So at this moment, I would just want to take this opportunity to invite the rest of the participants to ask any questions to the presenters, Denise and Peter Mount, regarding eye health care in Jinja and perhaps in any other region in the country, and if there are any opportunities that we see where any partner could contribute anything, it's welcome, ranging from technical expertise, advice, if there's anything you can do in healthcare, supporting children, funding, and all those things. If there are any opportunities that we can identify after asking them questions and then answering them, then we can actually come up with some actions thereafter. So I throw it to the participants. Please, anyone with questions, you're welcome to ask a question.
Hello there, it's Catherine Hannaway. I was very interested in your work. It sounds as though you've had some tremendous achievements. Well done. My interest here is I work with Lord Nigel Twist, we are running a global campaign around nursing, of which Uganda is very much taking part. Last week I was in Cambridge at the Adam Brooks Abroad event, where they talked quite a lot about work on eye health that they have been involved with, or people they work with, including initiatives like PEEP, which had been running in Botswana and I think Uganda. I was just wondering how connected you are with, all these different schemes that run, and how, you're able to work together with different people who are, particularly from the UK, taking expertise and sometimes resources in eye healthcare.
I think, Catherine, that's a really interesting question, because if you look at my own expertise, it's probably a very layman's knowledge about eyes. And through this project, because first of all, I felt I would just hand over to experts and they would take this on, and I would just and the problem was, if you didn't have a project, you didn't seem to be able to help. And it's almost like we started from nothing, and it's gathered momentum, because we found Priya, who's been brilliant. Then we found Primrose, who's opening different avenues up for us, because primarily we're an education charity, but also how can children learn if they can't see? And it's totally unfair that there are treatments out there that these children are not getting. So I think this primarily because I became quite angry that something could be done if we could just connect it. And so I'm making these connections. Peter might like to talk to you, because Peter used to be the chairman of Manchester Hospital, and got connections, haven't you, Peter, at a higher level. But we're making these connections, and we bought Sebastian a bikes, a motorbike, so we can go and find these children, because nobody seems to be doing anything about them. So although it seems that there are all these organisations and things are being done, we seem to have found somewhere where nothing was being done. Yeah. So it was almost like, well, should we do it ourselves? Yeah. And the big question was, well, how do we do it? And it's through all the work Sebastian's done, and the expertise that he's had, and the communication and the other connections that we've made, that things are starting to move. But I think one of the things we do need to do, and if you've got to roll with it, it's the people at a higher level, the people with the power, and don't repeat in this project. It's been like Primrose working extra shifts, having a few fundraising, because it's been done, if you like, on the side of the charity, because obviously our money goes to the building of the schools. Yeah. I mean, what from your expertise, what more do you think can be done?
Well, I'm just trying to gauge where your project is at and who you are working with and through. When I was hearing about the other eye health projects, in particular, they were using or working with nurses and teachers and they were training up those people to be able to do certain things. So I'm not just sure what role Primrose has and what she's able to do other than herself, if she's able to, you know, pull together other people to join in the effort.
She has actually, yes. She went over to Uganda 2 weeks ago, and she spent 4 days there making connections with lots of different hospitals and carrying out operations. This was going to go ahead before she joined with us, so we've become more. We're getting a bit more expertise, but while she was over there, she was also training some nurses in Uganda. And
Right.
we're now going to pay for 3 optometry students.
Yeah.
2, 3.
Is it 2? 2 over 3 years. So hopefully we will be able to have 6 extra optometry students. We are still struggling to find a pathway for the children we've identified to have operations.
Yeah.
And that's what we're hoping from this webinar. You know, we might be able to find somewhere that they can go, because when they went to the Mengo Hospital, they can only do so many because they've got their own patients also.
Yeah.
So we've got no direct pathway at the moment, but they have got the expertise in the country.
Yes.
But they're all private.
Yeah.
Anything you want to add, Peter?
Okay. I'm not sure if there's anybody on the call from the Uganda UK Health Alliance that can offer any view or suggestion or contacts beyond what you've already got there.
See, we find on if you like, on the group 1, we've got Priya, and we can set up more eye camps, and Priya can assess the children. Those that need the spectacles and drops, we're paying for. So we've got those children, if you like, that's a success because they're better. The group 2, the ones who need the operations, they have to wait for somebody like Primrose to come over and the team of doctors to be treated, or we have to keep finding a different pathway and then pay for them.
Yeah.
Group 3 is the group that's a real struggle because they need corneal grafts, and it's very, very expensive. It's about 4,000 at least for 2 eyes per child. And again, it's how is that done? Because these children are not seen properly, and while they're waiting, the time's going on and they're missing out on school, and their lives are not how they should be, because a lot of these eye conditions, if you have them in the body, they would be treated. I mean, Primrose's dream. Sorry, somebody's speaking. Primrose.
Been losing you.
Are you there, Henry?
I was trying to say that I'm not getting stable communication from you, but
Henry,
what I would say, if I heard what you were sharing, you guys were trying to share about what contribution Primrose is. The last thing I heard, I think, what contribution Primrose does have towards helping these children, and also you were talking about possibilities of identifying partners within Uganda who can help HUGs get a way of treating these children. Is that right?
Yes.
It is. Yes. So what I would say is that we definitely, there are great strides that have been made towards helping these children through Primrose, the contacts that we've been creating. We currently have so many others that we think are coming up through the iHealth consortium that is being formed. For example, I would share with you that during the time of the camp, we had a meeting at the Vice President's office with another team from the US called the UUKHA Foundation, who are very keen to do camps in the different regions of the country. They have so far done camps within Ruwero, which is within the central region, but they were happy to join. They came actually around the camp and they said they were happy to join the team that conducted the camp in Lubaga. And now it's going to be a synergized team that is going to do more camp in different regions of the country. Now with this team, we are foreseeing support in all different angles towards training, towards healthcare, and towards research. So we are looking also towards, we are envisaging having a fund that will be set aside to support all those different aspects that I've mentioned, all those different areas: training, research, healthcare, and training, research, and healthcare. Those are the three areas. Then financing comes in to support all those three. So we hope through meeting the different stakeholders on this, including the government officials or leaders, we think there will be an opportunity for creating this fund through the alliance, because that is one of our core mandates and our core values why we exist. Coordinating organizations, avoid or to reduce duplication, just to join hands so that the resources are combined when we are doing about iHealth. In the iHealthcare consortium, we shall be able to solve this problem of having healthcare for those children, especially the iHealth, since it's what we are talking about through the consortium.
Henry,
we are envisaging actually enormous. So we are getting more partners and more support. Unfortunately, I can't hear well. But I'm getting broken sounds. I'm so sorry, but you can go ahead and ask. Seems you're asking something, Denise.
Henry, I was just going to say that I've written a paper about this, and if somebody like Catherine would like a copy, we can have a copy, Catherine. Yeah. Yeah, and the slides.
You're part of the alliance, are you, Denise? Your organisation belongs to the Uganda UK Health Alliance.
Yeah.
Yeah. Are you? But you're not yet part of this eye care consortium.
No.
You're not integrated into that.
No.
Because it sounds as if, I know it's all new work that's pulling people together, but it sounds as if, you know, if you can become part of that same consortium, that you can begin to share your knowledge, your expertise, and you know, and the resources that between you, some may be able to do one thing, and you're very good at finding the children and adults who need treating, but other parts of the consortium are probably got more resource for offering treatment. So, yeah, it's you know, joining together, which sounds as though it's beginning to happen. It's about by the alliance.
Yeah. I'd like to send you the information, Catherine. I wonder how we send it. Catherine, do you have an email address?
Yeah, I still got a breakage somewhere. I missed some of the things, but according to what Catherine, if I picked somewhere, I picked the conversation from somewhere halfway, and she was advising HUGs to be part of the consortium. Indeed, a consortium is a model that we have tested, we have tried it out, and we are seeing it in other areas. It's working out well. It's through the consortium that we managed to have this camp, and then because we did some activity through the camp, through the consortium, more partners have been attracted, even from different other countries. So we believe that as we attract more partners from the different countries and the different areas of the world, we believe this is going to bring more synergized effort for you guys to share your expertise, your knowledge, and also to join efforts in looking for funds and other resources that may be necessary to support the children, and also to support other things we need in the eye health sector, where the things that I mentioned, the 3 areas that are very key: research, training, and then service delivery. And actually, service delivery is just one of the bits that would benefit these children most. Yeah. But I have said we shall have to create a fund dedicated to supporting these 3 areas. Okay? So I think it would be really amount or fundamental for the HUGs to be part of this consortium. Good enough I've joined with Primrose. Primrose is a very key person consortium, and it's because of her that we are seeing it moving forward. So we need such people like her, like you, Denise, join Sebastian being part of it, Priya being part of it, and we join with the other people who are more technical in the eye health sector, say of some part of it, so to have the team as in built in such a manner. There are other people online. Sebastian joined the team, and I would request Timothy to unmute him so that he talks to us. Maybe he could supplement on what Denise shared. Priya is also online. Sebastian, are you there? Can you hear us?
Yes. I'm happy to join.
Sebastian?
Yes, Doctor.
Sebastian?
Yes, Doctor. Are you hearing me?
Yeah, please go ahead and share something.
Oh, thank you, Doctor. I am happy to join you online, seeing Denise over there and Peter. I would just make some few remarks here and say that the consortium, as doctors put it, it is trying to help us to bridge the gap that has been there for so many years, that has led to many children becoming blind. And I would think that it is the way to go, especially if we can have more partners on board. We appreciate all the efforts that HUGs, Primrose are doing. My colleague here, Priya, we have done very little but very fundamental, and it gives us more energy and more hope that if we go on, we can save so many children from becoming blind. The most important is the human resource part of it. In Uganda here, we have very few doctors who can really handle the increasing number of children who are becoming blind. Leave out the adults. The adults is another big problem, but now looking at our focus area, the children, many children are not able to access full services as far as eye care is concerned in Uganda here. And go and qualify is the way to go. The team that came from the UK, joined by the local team here, did a lot of good work. Because for us as Jinja, we were able to have 22 children. Many are already testifying that they are seeing. So Probably, you never know. Akuya may have something to add on as I also look at other discussions that are going on.
Hello, hi everyone. So I'm Priya. I have.
Is it me who has lost Sebastian? The rest here, Sebastian?
Hello? Hello?
I can't hear Sebastian well.
Doctor, I'm hearing you.
Denise, are you hearing Sebastian?
I believe this is hearing me. Hello? Doctor.
Okay, I'll just come in with another point, if I may. My interest is how can we use nurses better to do some of the things where doctors are not available or short, but nurses could be trained to do some tasks that nobody else is currently doing. My interest in Uganda is particularly how can we use the nursing workforce. Nurses are 75% of the healthcare workforce in Uganda, and a lot of the time they're not used to their greatest potential. They're not trained to their greatest potential. And I think with the Nursing Now campaign, we have an opportunity where there are problems like this to be able to look at how nurses could be used better.
We're actually aren't we, being trained through our scholarship scheme. And we
Right.
training of one doctor at the moment. Yeah, 3 or 4 nurses were trained. Peter's just actually looking at the
Keep talking up.
yeah. But I mean, use your resources properly, haven't you?
Yes, use them better than currently we might be doing, and thinking quite creatively about doing just that.
I think
Where the resources is good.
I think just digressing slightly from this talk, what's occurred to me is, why are so many children in Uganda in need of eye care, and does it go further back to conception and when they're in the womb, and why we got this problem, and does there need to be more preventative measures? And I obviously don't know the answer to that, but that's something that has come into my mind. Why are we dealing with this situation? Is it to do with nutrition? Is it to do with, maternal health? And I don't know whether you've got any answers for that, Catherine.
Well, the people that I met last week who were running the PEEK, P-E-E-K project, many of them seem to be qualified eye doctors, and they have been doing research as they go about diagnosing children with eye problems, particularly going into schools. They had developed a new phone app, something that was an eye test that you do on a mobile phone. It seemed quite amazing, and the results they were getting were very good. It's how we combine their expertise and their research understanding with the practical aspects that you understand very well. And I think the consortium is a perfect example of bringing together all the goodwill and the resource that's there in order to fight for more.
Yeah, because we're actually acting in a reactive way, and it's whether it's more preventative.
Yeah, absolutely. I agree with you, Catherine Hanaway. That is the thing, and it's good you've shared about the PEEK project, and I think this is something that HUGs can also tap into. So our time is fast spent. We are almost getting to an hour. There is a participant online called Bob. Bob, can you hear us?
Our Bob.
Weird. Explain weird.
Yeah, if you can access Bob, he's one of our trustees.
Oh, he's one of your... Okay.
Bob Blundell, yes.
Okay. He's online, but I don't know. We've not heard anything from him.
It's Catherine. I just wonder if his microphone muted. If you're there, Bob, you unmute your microphone. I'm not sure if that's an issue.
Timothy can unmute him. Please unmute Bob and Priya. Okay. Maybe they have some technical challenges because I can hear so many noises in the background. Sorry for that. I think someone has noises in the background. I want to appreciate everyone who has participated in this webinar. We are almost at the time. Catherine, I would want to request you to give a word of appreciation and maybe to give us a very brief summary of the discussion, and then we can actually have a mail follow-up to each and everyone who has been in this mail will be this kind of discussion. We can move forward with discussion because we realize that there is a team of children. I mean, there's a group of children who still need care. So, yeah, please, Catherine.
Right. Okay. Well, Denise and Peter could probably sum up better. From where I'm sitting, and I'm completely new to hearing about this work, so it's been a real eye-opener to hear you're doing such good stuff, and to me the important thing is you're out there finding children and people who would otherwise not have been identified. I think that the key messages were about working together here. The consortium is, I think, in its infancy, and by you joining with that group of people, it will be very beneficial to everybody. I think they too will benefit from hearing about the work you've done and you sharing how you get out there to find people. I think everybody on the call can be mindful about potential support for you and be thinking of ways. And my own challenge is there is an opportunity for us to highlight the role of nurses at the moment in Uganda. So I would say it's a window of opportunity, so perhaps we can grasp that within this project and see how we could, use the opportunity to work better through the healthcare workforce that's out there, or teachers, or whoever is already available to work with. But fantastic stuff, and well done, and thank you for sharing it with us.
Thank you, Catherine.
Yes, thank you, everyone. We've not had as many participants, had technical challenges, but I'm really excited about the discussion that has happened between the team. Denise and Peter Mount and Catherine. Sebastian has chipped in. I think we've picked some ideas from here, And I would want to hear from Denise and Peter. Perhaps there are some suggestions you have, then we shall close right there.
I think, Henry, because we have had some technical challenges, it would be nice to share the paper and the slides.
Yes.
And just to say that we're obviously all working to the same aim, aren't we? We want these children, wherever they are in the world, to be able to see. And that's the challenge.
Absolutely.
And thank you for giving me the opportunity to share this with you. And it's been a pleasure to actually see Priya and Sebastian, who I've never met.
Wow. You've never met them?
We've never met. All this work between myself, Priya,
wow.
Sebastian and Primrose has all been done over the internet. We've never actually...
Wow. I'm happy. Yeah, we should actually. We are happy that the webinar has happened and you've had this interaction. You have at least seen them, though you've seen them online. This is the beginning. We are happy actually. We thank you for having accepted to be part of the webinar and for inviting them, and you've seen them. So thank you very much, everyone, and thank you very much, Bob. Thank you very much, and want to say bye. Bye.
Bye, thank you. Very good to meet you. Well done. Great work.
Bye.
Thank you.
Bye.